Hello, class. I'm going to talk about the concept of comfort in week 5, day 2, and our exemplar for that concept is acute and chronic pain. This exemplar is nothing new to you. We touched a little bit about acute and chronic pain in Nursing 100, but now we're going to look at it a little bit different to distinguish between the two. Again, go back and think about what pain is. Pain is an unpleasant sensory and emotional experience that's associated with an actual or potential tissue damage, or described in terms of such damage. All right, and that's what we have always done with our initial assessment, is to ask our patients, are you having any pain? That's what you did when you started your head-to-toe assessment. And then obviously the answer that we want to hear is no, but when we do hear the answer yes, that our patients are experiencing pain, we have to delve into that assessment in much more detail. We need to have that patient describe that pain. Where's that pain at? The location, the intensity, the quality, and the duration. It's very important to know where that pain is, because many times knowing where that pain is located will give us an idea of what the patient's major problem is. And pain can be a very negative experience, but you have to realize too that when we are alerted to the fact that we're having pain in some location of our body, it can actually be a blessing in disguise. And what do I mean by that? Well, if someone is having a heart attack, it's very important that the body recognizes that pain and sends the signal to the brain to alert the person that you're having that pain, so that the person can obviously do something about it and hopefully go to the hospital and have it checked out to determine if this is a cardiac issue. So pain can be a way in which we are told that something is not correct or something is not working well within the body. Intensity is very important. We might want to know how that pain, how intense is it? Is it mild pain? Is it moderate pain? Or is it severe? And in order to determine that, we, especially with our adult patients, we ask them, please tell me how severe your pain is, where 0 is no pain and 10 is the worst pain you've ever experienced. And that gives us a little bit more idea of how serious this pain is, because we do know what physiological effects can occur when someone is experiencing a lot of pain. Our goal as nurses is to definitely alleviate that pain, because we know it has a serious physiological response on the body. Blood pressure goes up, heart rate goes up, and over time, when someone is definitely experiencing pain, maybe chronic pain, not only does it affect a person's physiological health, but we know that it can also affect psychological health as well. Someone who is experiencing chronic pain on a daily basis may become depressed, withdrawn, socially isolated, and it can truly and definitely affect quality of life. Your book does talk, again, to remind you about some of the types of pain scales that we use, just depending on the age of our patients. The one that's described here on page 160 in your Pearson book is the Wong-Baker Faces Pain Rating Scale. And this is one that you see most popular with our children, because they can look at that scale and see those different expressions on these faces, and the nurse can say, hey, tell me how you're feeling at this time when we're talking about the pain that you're experiencing. And again, it goes into increments of 2, 0, 2, 4, 6, 8, and 10. And you can see where 0, the face is just as happy as can be, whereas the worst type of pain, the face is grimacing and also crying as well. So that just really sends a signal to the child that this is really, really pain that unfortunately makes them cry. And quality is also important as well. It can be expressed with certain descriptions like, yes, I'm having sharp pain, or it's a stabbing pain, or it is a burning pain. It feels like my feet are on fire. Maybe it can also be described as a dull ache, or maybe it can be described as a cramp. So those are some of the more detailed descriptions of pain that we as nurses need to know to further evaluate the patient's condition and to sometimes make that diagnosis. Your book goes on to talk about the pathophysiology and the etiology of pain, how it is triggered by the peripheral nervous system, which is outside our brain and spinal cord. Talking about the 2 types of neurons in the peripheral nervous system, sensory and motor, and I'm sure this is, brings back a lot of your learning from your anatomy and physiology. Nociceptors, or sensory receptors that respond to pain, those are the ones that send that signal along the sensory neurons to the spinal cord, where the signal is then taken to the brain, where then it's interpreted as, hey, I'm having pain in such and such an area. I won't go into a lot of details. Please be sure you read that over. And on page 161, there are types of pain stimuli. There's 5 different categories. Biological, which would be an example of caused by a bacteria or a virus, or mechanical, which might be caused by a shearing force or fracture. Thermal, that could be caused by a burn, or even someone who develops frostbite due to the cold weather. Or electrical, could be from an electrical burn or electrical shock. Or a chemical, which could be caused by a chemical solution, also by tobacco smoke, or by some type of acid or base. That might be obtained, like, say, for instance, if you were in some kind of laboratory, maybe doing an experiment in your classes, and you suffered from a burn because of the type of solution that your skin or your eyes came in contact with. Again, read a little bit about the pain theories, the gate control theory, which was quite popular back in 1965 by Melzick and Wall. And this is the one that's probably the most widely accepted pain theory to date. But it still doesn't kind of encompass everything that we know about pain. The types of pain that we're going to talk about, which is our exemplar for the concept of comfort, is acute and chronic brain pain, and then talking about breakthrough pain, central pain, phantom pain, and psychogenic pain are also discussed. So let's look at what acute pain is. That's pain that just occurs suddenly. Usually the cause is from some type of tissue injury. Maybe a person had surgery or had some type of inflammatory response, or else had some kind of traumatic injury. The duration of that acute pain is usually short. It lasts only until that particular area begins to heal. And sometimes we might see acute pain last for just a few minutes or up to a few months. Usually less than 6 months, we call that acute pain. But again, when we experience that acute pain, that autonomic fight or flight response goes into effect, causing those physiological responses. You start to breathe faster, your heart rate goes up, your blood pressure goes up, you start to sweat, your pupils become dilated, and you become very anxious. And the three primary categories of acute pain are somatic pain, visceral pain, and referred pain. And we did touch a little bit about those in Nursing 100. So let's look at each of those types of acute pain and see how they all differ. Somatic pain. This usually is basically described as a sharp pain. It can also be accompanied by swelling, cramping, or bleeding, and it usually responds well to mild analgesics. What's an example of somatic pain that helps to kind of understand what that is basically like? It might be if you cut your finger. Say you're preparing food and you cut your finger with a knife. That's somatic pain. Or maybe you overdid it in the gym and you pulled a muscle, and now your calf or your leg or even your back muscles are really feeling it. Maybe you lifted too heavy of weights and you overstretch the muscles, so that would also be another example of somatic pain. And then we have visceral pain, which originates from the internal body organs and the lining of the body cavities, very different from somatic pain, which originates from the nociceptors located in the skin and the musculoskeletal tissues. And visceral pain is described more as a dull, deeper aching. This is a pain that involves the internal organs that respond to inflammation, stretching, and ischemic changes rather than to lacerations or extreme temperature changes. So it presents itself a little bit different, and so that's how visceral versus somatic differ. And visceral pain often manifests as radiating or referred pain, and this one we need more of a stronger means of relieving this pain, primarily opiate treatment. And obviously examples of that would be if you're having a heart attack, you have cardiac pain, or maybe you've developed, as the book gives an example, urinary colic from the passing of a kidney stone or renal calculi. And then referred pain is sensed in a region other than the site of where it originally is at. And that's when the nerve fibers that innervate the injured region and nerve fibers from other regions of the body converge at the same level in the spinal cord. That's when we might have a problem with an organ, and maybe you start to feel the pain in your back. Say, for instance, if you have some kind of abdominal problem, maybe from maybe you're having a heart attack. Sometimes people present as having referred pain, or even though the problem is with the heart, people sometimes experience shoulder pain. Sometimes it radiates up to the jaw, or even down the left arm. So that's what we mean by referred pain. All right. So those are the three types of acute pain. Again, somatic pain, visceral pain, and referred pain. All right. And so it's important to kind of distinguish what type of acute pain your patient is suffering from. And then we have chronic pain, and this is pain that lasts beyond the expected time of healing, and that's where we see pain continuing for at least 6 months or longer, and sometimes we don't always know what the cause is, all right? And this pain can range anywhere from mild to severe, and over time, the body begins to adapt to this chronic and constant pain that the person is experiencing. Sometimes when you have an exacerbation of the problem, you might see those physiological changes occur that cause the patient to have high blood pressure, high heart rate, increased heart rate, and all those other things that we talked about with acute pain. Chronic pain has 3 main categories as well. The first one is chronic recurrent, and this is characterized by an intense episode of pain interspersed with periods of no pain. And an example of this is perfect if you've ever suffered from migraine headaches. It's not that something that continuously happens, but it is a chronic problem. Maybe you get them during times of stress. Maybe you tend to get migraine headaches during changes in hormone levels, but that's what we mean by a chronic recurrent pain. The next one is chronic intractable. That's always present, although the intensity of that pain starts to vary. And the most common type of chronic intractable benign pain is somebody that has chronic back pain. Okay, maybe by different movements, maybe by certain exercises, maybe you get that pain that comes back, but this time it's really, really intense. Sometimes it's just a matter of positioning as well. And then the third type is chronic progressive pain, and that is associated with a chronic condition that worsens over time, such as someone that might have cancer or maybe rheumatoid arthritis, something that's going to get worse and worse over time. So those are the 3 types of chronic pain as well. And then we have breakthrough pain, and that's an important term. It's a transient exacerbation of pain that occurs either spontaneously or in relation to a specific predictable or unpredictable trigger. And there's 3 types of breakthrough pain, okay? Incident pain, idiopathic pain, and end-of-dose medication failure. And incident pain is more short-term. It's predictable pain that accompanies a movement or activity. Say, for instance, you just had surgery and you're doing all right, and then all of a sudden you get up on the side of the bed, you want to do some deep breathing, and maybe it gets you to start coughing. That would be incident pain that's caused by some movement that causes you to develop that pain. Maybe it's time to change the dressing on a wound. That would be another type of breakthrough pain, which is specifically known as incident pain. Then idiopathic pain is not associated with any known cause. This one occurs unpredictably, and it's a little bit harder to treat. And idiopathic pain usually lasts longer than incident pain. And then end-of-dose medication failure is pain experienced at the end of one dose of medication before the next dose is scheduled. For instance, maybe the patient's pain medication is ordered every 4 hours. Maybe about 3.5 hours later you start to develop that pain. It just really doesn't take you through that whole time when you're able to get your next dose of pain medication. So that's what we mean by end-of-dose medication failure. Okay. End-of-dose medication failure can be prevented by shortening the time between doses or maybe increasing the dosage. So maybe you have some morphine ordered every 4 hours. Either Maybe it's only 2 milligrams and it just doesn't seem to do the trick. It only lasts for maybe 2 or 3 hours and you're not to get another dose for another hour. And it's very difficult to wait around for that next dose because you're in a lot of pain. So what you might want to convey to the physician is either we up that dosage and still continue to give it every 4 hours, or maybe we'll give that 2 milligrams, but now we'll make it every 3 hours. So do you see why we can hopefully work through that end of dose medication failure? And then we have central pain, and that's caused by damage to the nerves in the central nervous system, which can be due to stroke, multiple sclerosis, Parkinson's disease, or trauma. And central pain usually occurs shortly after the causative injury, or sometimes we don't see the symptoms or that pain occur until weeks or years after they've been diagnosed with that problem. A lot of this type of pain, central pain, can be described as pins and needles, aching, or lacerations. And sometimes as a result of this pain, a patient has a decreased ability to feel that normal touch as a result of this constant pain. Then we have phantom pain, and we know that that occurs after someone has had some limb amputated or some body part removed. Phantom pain is usually recurring rather than constant, and patients often describe their pain sensations as shooting, stabbing, squeezing, throbbing, or burning. And some patients may feel that limb is being forced into an uncomfortable position. They still get that signal to the brain that that limb is still there. And phantom pain is associated with neurologic activity in portions of the brain that were once connected to that amputated part. And then we have psychogenic pain, and that's pain associated with psychologic factors, including a lot of mental or emotional problems, rather than physiological factors that occur because of some disease or injury. But really, you have to be sensitive to this type of pain. Many times patients that develop psychogenic pain are very much judged, but for them, this pain is no less real than for somebody that just had surgery. So we want to be very respectful of that as well. So that's just a little bit about the various types of pain and how we differentiate between acute and chronic pain. There's a great bit of information on page 165 that talks about barriers that prevent patients from getting adequate pain relief, because that's something we should definitely hope to achieve, that our patients are comfortable and that they are getting adequate pain relief. So please make sure you go over that. It's very interesting and very beneficial as to what we can do for our patients to relieve that pain. And of course, part of the treatment of pain is definitely pharmacologic therapy, which I'm definitely not going to go into because you're getting that information in your Nursing 123 class. But we do use medications as a means to relieve our patients with their particular kinds of pain. All right, and I just wanted to go over a couple of other things. When we talk about age groups across the lifespan, there's a nice table on page 174 that talks about influence of age on pain perception and behavior, beginning with infant to toddlers to school-age children, adolescents, adult, and even the older adults. There's a chart that gives a description of the response to pain, and what type of non-pharmacological interventions that we as nurses can do with that particular age group. I'm not going to go over those in detail, but it would be important to look those over, especially if, after you graduate, you are working with children, whether it be, infants or, toddlers, or working on a pediatric unit. It might be important to kind of get some ideas of how we could help definitely assess the pain in that child, but also to provide interventions that hopefully relieve that pain as well. All right, so let's go over this PowerPoint. I think that helps a little bit to kind of review some of your sign reading. Okay, so let's go over this. And as with always, with every PowerPoint, we have learning outcomes. A great way to test your learning after you read your chapters and review this PowerPoint. So as we have here, pain is unpleasant and is very highly personal. We all have different pain tolerances. Something that's a pain level of a 7 for you may only be a pain level of 3 for me. It's both physical and emotional, and it may be imperceptible to others. And pain can consume all parts of a person's life, and it involves both sensory and emotional experience. And pain is whatever the client says it is. So we never question to say, oh, there's no way you could be having a pain level of 10. You're on the phone talking, or you're watching TV and you're laughing. We never question a patient about what they tell us about their pain. It exists whenever a client says it does. And again, as what I just said, it described in terms of location, intensity, quality, duration, and can be medically described based on etiology. And location is a classification of pain based on where it is, and it may be useful to give the primary indication of that underlying cause. Radiation, meaning the pain will radiate to other areas of the body or extend beyond that primary area where the actual problem is, or it can be referred, appears to arise in a different area of the body. And then, of course, we look at intensity, where we look at mild, moderate, and severe. On that standard 0 to 10 pain scale, 1 to 4 is considered mild pain, 5 to 6 is considered moderate pain, and 7 to 10 is considered severe pain. And again, visual scales, and I talked about the Wong-Baker faces, which we use most often with our pediatric patients. And these are words that you may have a patient describe that pain. Quality might be stabbing, burning, itchy, tingling, cold, cramping, aching, dull, tender, sensitive, shooting, numb, radiating, throbbing, and having. And again, here's the pathophysiology of pain. I'll let you read that. Remember, nociceptors located at the ends of small afferent neurons, all tissues except brain, especially numerous in your skin and muscles. And again, read over these pain theories as well. Pain neuron specific and unique, uses sensory neurons separate from other sensations. So you can read those over as well. And this is more of what this gate control theory is all about. And again, looking at nociceptive pain results from external stimuli and uninjured, fully functional nervous system. neuropathic pain. That could be caused by nerve malfunction or injuries resulting from trauma, disease, chemicals, infections, and tumors. It also may be due to damage of peripheral central nerves. We find neuropathic pain a lot with patients that are diabetics as well over time. The high blood glucose will affect those peripheral or central nerves. All right, now let's look again at what acute pain is. Sudden onset, it's usually caused by an identifiable tissue injury. Typical autonomic response duration is less than 6 months, just until that injury heals. And of course, we just reviewed and discussed the 3 categories: somatic, visceral, and referred. And then chronic, that's more of prolonged pain beyond 6 months, not always a known cause, physiological adaptation of autonomic responses. And again, 3 categories with that would be recurrent, chronic intractable, benign, and chronic progressive. And then we look at breakthrough, which I just talked about, and what are the 3 types: incident, idiopathic, and end-of-dose medication failure. And then we have central pain, which is caused by damage to nerves in the central nervous system due to stroke, MS, Parkinson's disease, or trauma. And again, that could happen immediately or it can be delayed. And many times this type of pain is described as burning, pins and needles, aching, or lacerating. And then, of course, phantom pain, which is associated with an amputated limb or body part. It can usually recur versus constant. And these are the way we would hear the patient describe that type of pain. And then we have psychogenic, which is pain associated with psychological factors versus physiological factors. But remember, the pain is very real to that individual, and treatment should include interventions for pain and for emotional distress. So here are the risk factors. Internal and external environment factors can make clients more susceptible to pain, and there's some barriers that prevent adequate pain relief, and that could come from perspective of patient and family, barriers from perspective of healthcare providers, and barriers from perspective of healthcare infrastructure. And of course, prevention, being safe, avoiding areas that could cause an impending injury. So we would encourage people to be safe and use safety precautions, living a healthy life, getting adequate pain relief, and being compliant with pain medications without abusing them as well. And body's response to pain complex process is physiological and psychosocial aspects. Pain fibers become sensitized, and you have that psychosocial effect. And uncontrolled pain alters metabolism, and uncontrolled pain impairs the immune function as well. So again, looking at lifespan and cultural considerations. For each client, there is a unique set of factors that have influenced how they perceive pain, and that depends on physiological factors, developmental factors, the ethic and cultural values. If you remember when we talked about cultural diversity, some people consider pain as a punishment. Others will not admit they have pain because it shows signs of weakness in their culture. So that has a lot to do with how they perceive their pain, and of course their environment and the type of support they get. And definitely what's their past experiences with pain. Oh my goodness, my mother had cancer and she suffered, and she was in constant pain, and her physician would not give her anything. So these kinds of experiences are embedded in our mind, and that's kind of the sense of what we see happens with anybody who has pain, just because of your own personal life experiences. And then, of course, by developmental stage, clients' age and development stage affect how they express pain and respond to pain. And that's where I said to definitely look at that chart in your book that's in your assigned reading. I won't get into a lot of detail with this. You can read this over about children in pain, but what we see and how they kind of behave when they are having pain, especially if it's untreated, can affect growth and development, decrease their immune function. You might see them lack the desire to eat or lack of appetite. They may develop hypertension and increase sensitivity to future pain. And a variety of behaviors in response to pain. Changing behavior is one of the best indicators of pain. You know, the child was, having a good time playing in the playroom, and then all of a sudden he's become very withdrawn, crying out, maybe even resorting to bad behavior. So these are some of the barriers that we see to pediatric pain: inadequate pain assessment. We don't really assess pain with children, and inadequate knowledge and misconceptions about pain in infants and children. And then pain in adults. Chronic pain is widespread among adults, more prevalent among women than men. Women are more likely to develop pain-causing diseases and lower pain threshold intolerance than men. And men more susceptible to pain from cluster headaches, heart disease, gout, duodenal ulcer, and pancreatic disease. And most older adults have chronic pain. Physiological changes of aging affect perception of pain. Drug interactions, because many of them are on a numerous amount of meds. And some of the barriers that we see to their pain management is inadequate knowledge of healthcare providers, fear of pain medication dependence, and that's a big one now with all the media's publicly talking about all the overdoses that we've seen, and of course non-compliance, and of course the financial barriers. And cultural and personal factors will determine the meaning of pain. Variation in verbal and behavioral responses, and culture plays a critical role in pain expression and management. Nurses have own attitudes, expectations, but must provide culturally competent care. Be respectful of their culture. And of course, first of all, within each culture, we need to know what the meaning of pain is to that particular person. Positive view of pain may result in higher tolerance, decreases possible development of depression and anxiety about pain. Negative view of pain may bring feelings of hopelessness, depression, and anxiety, and prevents that person from enjoying life. And really it lowers their quality of life physically, emotionally, and socially. And environmental and social support. Strange environment can compound pain. Lonely person without a support network may definitely affect how they perceive their pain. And family education can positively affect perceived quality of life and expectations of significant others. And I think this is important to know that what is that person's previous experience with pain. Clients who have undergone procedures without adequate pain management, maybe they had some bedside procedures where they were not given enough, local anesthesia. Maybe they woke up during their surgery and felt pain. Maybe someone has seen a loved one suffer, and this will influence how clients perceive efficacy of future treatments. So effective pain management requires a collaborative team to manage pharmacological therapies and non-pharmacologic therapies. We have a lot of good pain clinics out there, and some physicians just specialize in treating pain, especially chronic pain. And just remember that no lab tests can directly measure pain. So that's why we use pain scales used to gauge the client's pain level, and looking at some of that objective data such as vital signs. We might see an increase in stress hormones such as cortisol, which may indicate that the patient is suffering from pain. And of course, surgery may be first step in alleviating severe pain, and recovery from surgery can involve short-term pain. And I'm not going to get into these pharmacological therapy. We're going to just bypass that because we're not going to talk about that in Nursing 121. I think this is important data. When we talk about the nursing process, 43% of American adults suffer from some type of chronic pain, and this uncontrolled pain may lead to depression, sleep disturbances and obesity, changes in the nervous system, accelerated disease progression, and increased hospital stay. All clients should be asked if they are experiencing pain, which we do with every time we do their vitals, and many clients do not voluntarily complain about pain, and that's why it contributes to poor prognosis. That's why they don't get adequate pain relief, because they don't tell somebody that they have it. So again, client interview, which should entail an illicit description of your patient's pain with location, intensity, duration, and quality. Asking them about current pain, start of pain, what caused it, things that worsen it, that trigger it, methods that relieve it, and other symptoms. What is your pain history, previous diseases, injuries, and what do you use to control that pain, and what does pain mean to you, and how do you cope with it? And of course, the various pain rating scales, numerical, FACES pain scale, the verbal descriptor scale, observational scale, and helps track changes in pain over time. Combination with pain flow sheet may improve pain management. And a good way to determine if a patient is having any pain is just do that visual assessment where we look at the patient's behavior. What are their facial expressions? How are they, what's their body movement? What's their posture? Are they gripping the sheets, just like we saw in that patient the other day where we did that case study? And this is especially important in newborns. Their behavior will change quite drastically to identify that they are having pain. And of course, that physical assessment where we look at vital signs. What's the trend been? What's their blood pressure been? Now all of a sudden they've got a 160 over 90 blood pressure. Their pulse has been pretty much in the 60s and 70s, and now it's 110. They've not been breathing very fast, but now their respiratory rate's at. So let's inspect for injuries and palpation of specific location. Maybe this where we would check their abdomen and observe it, do the visual assessment, where we'd inspect, and then of course we would auscultate, and then followed by palpation. And these are just some of the nursing diagnoses that we would come up with: impaired physical mobility, fatigue, activity intolerance, deficit knowledge, and anxiety. We might also see patients who have acute pain, may have disturbed sleep patterns, risk for infection, and impaired skin integrity. And for those patients that are experiencing chronic pain, this may be a diagnosis that you would see: insomnia, hopelessness, imbalanced nutrition, social isolation, and self-care deficit. And again, some of our patients who are prescribed opiates, these may be nursing diagnoses that correlate with taking opiates, where there's a risk for constipation, ineffective breathing pattern, fear, and of course nausea. So if your patients are experiencing nausea, you might want to give them an antiemetic before that medication is given. And this just goes on to kind of write a planning or an outcome of what we'd like to see. All right, so that's pretty much the PowerPoint that has to do with acute and chronic pain, and then going over some of your the key points from your assigned reading. So let's look at some activities, all right, that are from your appendices. What I have here is just a little activity or exercise that kind of differentiates between a particular problem and would this signify either acute or chronic pain. Again, the boxes tell you with acute, the onset, duration, the cause and manifestations of what you would see the patient exhibit, and then of course chronic pain, the same thing, onset, duration, cause, and manifestations. So let's look at these examples of pain in our patients and choose whether or not they are acute or chronic. Fibromyalgia, chronic. Diabetic neuropathy, chronic. Burns, acute. Infection, acute. A fractured femur, acute. Sprained ankle, acute. Labor, acute. A laceration, acute. Arthritis, chronic. Migraine headache. Could be a one-time thing, or we could see it as a chronic problem as well. And cancer would be chronic, and low back pain or strain would be chronic. And that kind of, and we can even get into more detail where we can specify, you know, is it, you know, chronic, intractable, or anything like that. We could get into more description. But for the most part, just helping you understand the difference between acute versus chronic. And when we have patients that do have chronic pain, it's important to find out a little bit more about their chronic pain. How has this affected their life? Do they know the cause of their pain? You know, yes, if they have arthritis, they say, yeah, I have a lot of problems walking, my mobility's been affected. Or they get migraines frequently. Maybe we could look into what kind of treatment we could provide from those patients. Because a lot of times people think, oh, I just have to live with a problem, but it may not necessarily be so. All right. I just want to say that this next activity that has to do with the pain articles on infants and frail elders. We're not going to do this because this would be an activity we would have done in class, where I would have split the class. Half of them read the article on managing pain in frail elders, and then the other half would read the article about management of pain in the pediatric patient. We're not going to do that now since we're doing our course online. They're very interesting articles because I think sometimes we have the myth that people that are older don't experience any pain, and that could be farthest from the truth. And the same goes with kids. We don't think kids have pain either. So that's what these two articles were trying to imply, that we do see pain in both of these age groups. But for now, we're going to not participate in these in that activity. So let's look at Appendix 37. And I think these are very individual responses, but I want you to think about how you would answer this, and this really makes for great discussion. I would have broken you up in two groups, and we could have gotten some feedback from each of the groups as to how they would answer this. And the first one is list the components required for an individual to feel comfortable, and consider more than a relief of pain. So what is it for you that makes a person feel comfortable? What has to be present in order for someone to feel comfortable? And that might be physical or even mental. You know, I just hate having a lot of stress in my life. I wish I could control that better. So what things make you uncomfortable? Are you uncomfortable if your hair is dirty? And how do you feel if you haven't been able to get a manicure, or take a shower, or trim your nails or facial hair? And this could be what a lot of us are going through now with our social isolation. We haven't maybe got our hair done. Maybe our hair's out of control. Maybe people who dye their hair, their roots are coming in. Maybe you're not showering as frequently as you used to because you're not getting up and going to work every day. Maybe that was your therapy by going out and getting a manicure or getting a pedicure, and you can't do that anymore. And you used to find that as an outlet to help relieve a lot of your anxiety and stress. So think about what it is that makes you uncomfortable. Compile a list that describes all the requirements for people to be comfortable, and then relate how you would incorporate this list into the care of your patients. So we can bring that list into the kind of care that is delivered to our patients. So we want to think of what our thoughts were as to what made us comfortable or uncomfortable, and let's relate that to a patient. So that's why it's so important. You know, it might not seem that important, but just those basic elements of care can make such a difference in the day of a patient. I know they love having students take care of them. They're very attentive to patients with their nail care, or maybe they help a patient wash their hair, or maybe they encourage the spouse to bring in the beautician that usually does their hair on a monthly basis, to bring them in and do their hair. So all these things are really important. Or maybe bringing in a favorite blanket that we could put on the patient's bed, or a favorite pillow. So all these things could bring comfort to the patient and help them feel comfortable and help them get through the stresses of this particular hospitalization. So think about this. And so how might culture affect this list? Maybe it's all about food too. Maybe they really don't like the type of food that they're getting in the hospital. Maybe that's making them uncomfortable. So think about how culture will affect this list as well. Maybe having family around all the time within a certain culture is very comforting to that patient. And now we know that's been definitely changed with hospitals not allowing family members to be in, maybe just one person with visiting hours or whatever. So just something to think about, okay? So I'll let you do that on your own, because I think there's really no wrong and right answer. But again, think about what is important to you, may be just as important to your patient, and to be sure that that particular comfort measure or measures are delivered to your patients, okay? All right, class, what I have up here is it's a website, WebMD, that talks about acute and chronic pain. It's just a great website for people and how to manage their pain. And as you can see, tips for managing chronic pain. Let me click on that and I'll show you. And these are some 11 tips for living with chronic pain. The first one is learn deep breathing or meditation to help relax you. The next one is reduce stress in your life. Stress intensifies chronic pain. Boost chronic pain relief with the natural endorphins from exercise. so that's what's on this website, okay? And then for acute pain, sorry, this is not being very cooperative, but here it is. It says, what is acute pain? Some of these acute pain, what is acute pain? Is your pain acute or chronic? And so videos for over-the-counter pain medications. So a very, very helpful website. So make sure you look at that, because this may be a website you may advise your patient to go into to help with some of their issues with acute or either chronic pain. Okay? All right, lastly, what we're going to do is we're going to go over some questions to just see how much you remember and learn from the PowerPoint and from what I just got done talking about. All right, question 1. A Klein indicates an intensity of 8 on the 0 to 10 pain scale. The best action for the nurse to take is which of the following? Number 1, check back in 30 minutes to see whether the pain has changed. Number 2, give pain medication. Number 3, further assess pain to determine the best intervention. And number 4, do nothing because the pain is at a tolerable level. Now I know you know this, so think about it, and then we'll move on to the next slide to see what's the answer. Oh, I know you got it right. Good job. It's number 3. Further assess pain to determine the best intervention. You know, interpret what that 8 out of 10 pain scale means. So a rating of 8 on the 0 to 10 pain scale is the patient is experiencing severe pain. And since most physicians order more than one type of pain medication, it is important for the nurse to further assess the type of pain in order to provide the best intervention. For example, if the pain is a headache, a non-steroidal anti-inflammatory agent would likely prove effective. So, makes sense, absolutely. All right, let's go to question 2. The nurses evaluate a client's pain. When documenting the pain, the nurse remembers that pain is, number 1, whatever the client says it is. Number 2, described only in objective terms. Number 3, the same for everyone. And number 4, managed only through opiate intervention. Now I hope that you got out of what I said from the PowerPoint will definitely help you answer this question. And the answer is, of course, you got that one right. Whatever the client says it is, all right? And the rationale behind that is, pain is whatever the client says it is, wherever the client says it is, as intense as the client says it is, and lasting as long as the client says it does. Pain is described most completely in subjective terms. It can be verified in part by objective data, such as changes in vital signs, and pain is highly individualized. Very good. All right. Question 3. When describing pain, the client states the pain is dull, aching pain. The nurse determines that this description tends to indicate that the client's pain is most likely and the choices are number 1, neuropathic, number 2, visceral, number 3, referred, or number 4, phantom. And I got done talking about that. I did say that earlier. And the answer is visceral. Good job, everyone. I know you got that one right. And the rationale is that dull aching pain usually indicates visceral pain, which is deep pain from organs. Neuropathic pain tends to cause stabbing, burning, and sometimes deep aching pain. And referred pain is at a site other than the origin. For example, pain from a diseased gallbladder may be felt in the shoulder, chest, or back. And then, of course, phantom pain may be felt in the stump of a limb that has been amputated, feeling as though there is pain in the limb that is no longer there. And then question 4, the nurse is evaluating a client's pain. The client states that the pain is at level 2. The client is indicating which of the following about the pain. So what does that indicate? Is it duration, number 1, number 2, intensity, number 3, quality, or number 4, onset? And you all know that answer. Of course, it's number 2, intensity. Good job. And I won't even do number 5. You can look at that one on your own, okay? All right, this concludes week 5, day 2. That has to do with the concept of comfort, where our exemplar is acute and chronic pain. Let me know if you have any questions, and be sure that you read your assigned reading. And one thing I wanted to mention in the weekly lesson plan, you'll notice under the reading assignment before class that number 2 says choose an exemplar with faculty approval to present in lab week 7. Obviously you don't have lab right now, so that's not something you have to do at this point. So because obviously this is a very different way of how we are delivering this information to you, and since you don't have your Nursing 121 lab with your class, your lecture, just disregard that. We'll get back to that at a later time. All right, so if you want to, you can look at question 5, but I would never ask a question about this. It just has to do with A delta fibers, which is following types of what kind of pain. So this is uploaded in your Canvas course, so you can use these as a review. All right, but be sure that you understand the different types of acute pain and the different types of chronic pain as well. Thank you so much for your attention. And thank you all for your hard work. You're all doing great. But let me know if I can help with anything or answer any questions. Enjoy your day.